Hi, this is Peggy O'Connor, and this is part one of the pre-class assignment, and it's talking about commonalities and maturational differences in the respiratory system in children. Definitions, you need to look up the definitions for the following: retractions, stridor, nasal flaring, grunting, wheezing, and crackles. All of these I will be discussing later on in this unit. Work of breathing equals an effort or labor associated with respiration, and I'll be discussing that in more detail as well. Prevalence of respiratory illness in children is increased because of the incidence of respiratory disease in younger child. Their immunity is not as developed as in adults. The population statistics support this, and through the transmission of infection, which is usually hand-to-hand contact or hand-to-secretions contact. As part of the Healthy People 2020 initiative, the goal is to decrease the incidence of otitis media in children and adolescents, and we as nurses can help to achieve that goal by teaching children and families the importance of hand washing to avoid the common cold, teach families the importance of keeping follow-up appointments to ensure the eradication of otitis media, and educate the families about the importance of using antibiotics only for true bacterial infections. These are the normal respiratory rate ranges for the newborn, infant, toddler, preschooler, school age, and adolescent. And as you look at them, you can see that as the newborn infant grows into adolescence, that the low and the high end of the ranges decreases, and that by the time they're an adolescent, it's pretty close to what an adult's respiratory rate is. But the newborn's rate and the infant's rate is quite rapid. However, a respiratory rate of 60 or greater is significantly higher than the norm. So you would want to absolutely know that fact. Regarding variations in the pediatric anatomy and physiology, your textbook goes into excellent detail regarding this, and it is found in chapter 28, pages 1388 to 1391, and it will tell you the exact differences between the nose, the throat, the trachea, the lower respiratory structures, the chest wall, the metabolic rate, and oxygen need. I will go into detail on some of these, but you should read all of those and take notes on it. One of the key points in the variations in pediatric anatomy and physiology is the lumen of the trachea. In a normal infant, the lumen is 4 millimeters wide, diameter-wise, and 2 millimeters in radius. In a normal adult, it's 10 millimeters in diameter and 5 millimeters in radius. So if there is a 1 millimeter circumferential edema, that is going to cause a 50% reduction in the size of the lumen regarding the diameter. So instead of the diameter being 4 millimeters, it's now 2 millimeters. And the radius is now down to 1 millimeter instead of 2 millimeters. Where in the adult, a 1 millimeter area circumferential edema is going to reduce the size of the lumen to 8 millimeters diameter-wise and 4 millimeters by the radius. And so the resistance factor in the infant is increased by a factor of 16, where the pulmonary resistance factor in the adult is increased only by 2.4. The difference in the pediatric ear versus the adult ear is that in the adult ear, the eustachian tube is longer here, and it is more vertical, where in the child, you have, this is the external ear and the eardrum. Here is your eustachian tube. It's shorter and it's more horizontal. So it is much easier for fluid to back up the eustachian tube and enter the middle ear, thereby causing a middle ear infection. When we care for a child with an acute respiratory disorder, we will be talking about caring for the child at home, since that is the best place for a child to be, emergency care, and hospitalized care. These are diagnostic tests that are done with children who have respiratory issues. The chest radiograph, arterial blood gases, fluorescent antibody testing, pulse oximetry, rapid strep test, and throat culture. You need to go to pages 1397 and 1398 in your textbook and look them up and see what it has to say. These are more diagnostic tests that are found on those pages. A lot of these are going to be used in the material that Lisa will be covering, and it's allergy skin testing, peak expiratory flow, pulmonary function tests, RAST, radioallergosorbent test, sputum culture, and sweat chloride test. These are the last of the diagnostic tests that are performed on children with respiratory issues. We are not covering the specific diagnoses that these diagnostic tests diagnose, but you should still look them up. Tuberculin skin test, sinus radiographs, rapid flu test, gastric washings for AFB, and fluoroscopy. Some of the common medications for children with respiratory disorders are antibiotics, either oral or parenteral, and that's to treat a bacterial infection like tonsillitis. You need to check for allergies and give as a prescription for the full number of doses. Beta-2 adrenergic are short-acting, and they relax the airway and they decrease wheezing generally in the lower airway. Racemic epinephrine is used for croup. It relaxes the airway and is generally used for upper airway issues. Corticosteroids, both oral and parenteral, suppress inflammation, and they can be used for severe croup and may cause hyperglycemia. So they may also suppress reaction to allergy tests. So you would need to consult the practitioner if vaccines are due, and a short course is generally very safe. More common medications, Virazole or ribavirin, is for treatment of severe bronchiolitis. These children are usually intubated. They usually need suctioning every 2 hours. You would need to check the pulmonary pressure every 4 hours. And there is a great concern regarding administration by the pregnant caregiver, as it can affect the fetus. Synagis or palivizumab is the monoclonal antibody, and it's used to prevent serious lower respiratory RSV disease in high-risk children, and it's administered monthly during RSV season and is given as an IM injection. This is a photograph from your textbook, and it's showing about 3 different methods for administering oxygen. There is a fourth one. The first one is your non-rebreather mask. Your second one is a nasal cannula, and the third one is a rebreather mask. And the fourth one, which is not shown here, is blow-by oxygen, where you take either a scoop mask or you take just the corrugated tubing that would go to the scoop mask and wrap a towel around the end of it so that you can prop it so that the oxygen blows by the infant. And as it's blowing by the infant or child is breathing it in and getting oxygen by that method. Interactions with non-nursing interprofessionals would include physical therapy, respiratory therapy, nutritional services, social work, and child life services. There's a link here for the child life services at Tufts Floating Hospital, and it's really a wonderful little video clip, and I would like you to please check it out. Thank you. I have a question here for you to practice. A 4-year-old is seen in the clinic for a sore throat. The most likely causative agent in the child's mind is that he, A, was exposed to someone else with a sore throat, B, did not eat the right foods, C, yelled at his brother, or D, did not take his vitamins. Please pause your video for this. Try to answer it on your own, because the next one gives you the answer and the rationale. So, the correct answer for this is C. He yelled at his brother. Preschoolers understand some concepts of being sick, but not the cause of the illness. So, A would be out. They are likely to think they're sick as a result of something that they have done. They frequently will view illness as a punishment, and they don't understand that he could get sick from exposure to someone else who is sick. The other 2 answers could be factors in some illnesses but are beyond the thinking of a 4-year-old. This is the end of part 1. Please go on to part 2, and thank you very much for your attention.